2022. I'm Dr. Fiona Tuhebwe, your moderator for today. We start with some housekeeping as a reminder. You can choose the language in which you'd like to hear the press conference by turning to the globe on the bottom right and selecting your language. You will have an opportunity to ask questions, and to do this, please use the question and answer function on the Zoom application. Please remember, you will need to provide a name and the news agency you represent to have your question answered.
Bonjour à tout le monde. Vous pouvez choisir la langue dans laquelle vous souhaitez entendre la conférence de presse en cliquant sur le globe en bas à droite et en sélectionnant votre langue. Vous aurez la possibilité de poser des questions. Pour ce faire, veuillez utiliser la fonction questions-réponses de l'application Zoom. Et n'oubliez surtout pas que vous devrez fournir votre nom et le nom du média que vous représentez pour que votre question soit posée. Over, Fiona.
Thank you, Khadija. So joining us from Brazzaville today in Congo is Dr. Abdusalam Gay, the Regional Emergency Director at WHO Region Office for Africa. And I'll now let Dr. Gay introduce our other panelists. Dr. Gay, your mic is muted.
Good morning and good afternoon to all journalists joining us. Welcome to our first press briefing of 2022 to discuss the latest trend in the COVID-19 pandemic spread. I am pleased to be joined by Dr. Anita Graham, who is an intensivist at the University of Witwatersrand in South Africa. She will tell us about she's handling COVID-19 patients during the country's current surge. The world has entered the third year of the COVID-19 pandemic. The virus has caused great devastation. Millions of lives have been lost and livelihood wiped out. Here in Africa, cumulative case has now exceeded 10 million and more than 230,000 people have sadly died. In its ongoing march, the virus has evolved and formed new variants, some of which have been extremely virulent and deadly. We are now wrestling with the fast-spreading Omicron variant. So far, 30 African countries have detected and reported the Omicron variant. In the hardest hit countries, Omicron has quickly become the dominant variant. It overtook the Delta variant within 2 weeks or less. Comparatively, it took around 4 weeks for Delta to surpass the previous dominant Beta variant. Encouragingly, after 6-week surge, Africa's fourth pandemic wave that has been primarily driven by the Omicron variant has recorded its first drop in cases. In this trend continue, this marks the shortest life surge to date in the continent. But we are still very cautious because the latest data we got was collected during the holiday period, which is known to underreport. Over the past week, cases plateaued compared with the week before, dropped by a little bit, 0.2%. Infections have also declined in 3 of Africa's 5 sub-regions. Only North and West Africa are currently witnessing an increase in cases. Across the continent, deaths rose by 64% in the past week, mainly due to infection among people at high risk. Nonetheless, fatalities recorded so far in the fourth wave remain below those in the previous waves. Hospitalizations have also been low. In South Africa, for instance, around 9% of its over 5,600 intensive care unit beds are currently occupied by COVID-19 patients. Although Africa appears to be emerging from the peak of its fourth pandemic wave, vaccination, which is a pivotal measure against this virus, remain far too low. About 50% of the world population is now fully vaccinated. In Africa, this is just 10%. Only 7 countries met the target to vaccinate 40% of their population by December 2022, and just 26 have vaccinated 10% of their population, a target that was to be reached by September last year. Currently, vaccination bottlenecks are less about supply than they are on rollout. At WHO, we are increasing our support to countries to fast track and effectively deliver the COVID-19 doses to reach a much wider population. Specifically, we are working with governments to resolve cooperation challenges that include refining and implementing vaccine rollout strategies, pledging funding shortfall, as well as boosting collaboration with community for increased vaccination uptake. The core objective of COVID-19 vaccination are to limit severe infection and death, as well as safeguard hospital and health workers from being overwhelmed by surging infection. At the current vaccination rate, Africa is running too far behind. The coming months will be critical in Africa's effort to improve vaccination. The continent cannot afford to remain the fringe of this historic vaccination drive. I thank you once again for joining and look forward to the discussion.
Thank you so much, Dr. Gay, for that introduction. So Dr. Anita Graham, we're excited to have you. And could you kindly tell us about the testing and treatment for COVID-19 and the challenges and lessons you've learned from management of Omicron cases?
Firstly, I'd just like to thank you for inviting me to this very important briefing. Just to clarify, I'm a practicing pulmonologist, but yes, I do intensive care work in addition to that. So just to contextualize my experience, I work in one of 3 large academic institutions in Johannesburg, and Johannesburg serves a population of 5.7 million people. This translates into a very large number of patients that are served at our hospital. My hospital currently has the capacity to accommodate COVID patients in 6 medical wards, which provides around 170 beds. We also have 2 PUI wards, which is a person under investigation who have suspected COVID, in 2 other wards, which is 60 beds. We also have a designated 7-bed COVID ICU, and our emergency department can also capacitate an additional 60 COVID patients. So we're able to accommodate more than 250 COVID positive patients. To describe our current experience with this 4th wave, we are definitely experiencing a very large 4th wave of COVID, and 95% of all of these infections are of the Omicron variant, which is different to what we're seeing in North America. It's definitely the most contagious variant with a massive upsurge, rapid upsurge in cases. However, despite this massive upsurge in cases and infections, we're definitely also seeing the least of all severe COVID waves, which with much less hospitalizations and much less ICU requirements. The reasons for this are multifold. So the first one that we suspect is that we have got quite a strong pre-existing seroprevalence of immunity in our population, and it's estimated to be around 70%. And this is likely due to previous infection from the 2nd and the 3rd COVID waves. However, we know that this protection wanes over a period of time. The second reason for having slightly less severe hospitalizations and infections is vaccination, although, as described earlier, our vaccination unfortunately hasn't been taken up as much as we would have hoped. And the third reason is that Omicron is likely a slightly less virulent strain, which is what we expect with different strains to become more infectious and sometimes less virulent. However, we are still seeing very serious infections and admissions in patients who are unvaccinated, and also in patients who have comorbidity, and this includes the elderly population. Our vaccination remains the best, most effective way of protecting ourselves and our patients from severe disease, hospitalization, and death. Other important non-pharmaceutical interventions are of paramount importance. This includes mask wearing, social distancing, and of course, sanitization. The therapy for Omicron is the same as the therapy for all the other variants that we've seen in the COVID pandemic. And the mainstay of therapy remains oxygen therapy when patients' oxygen levels decline, corticosteroid use, as recommended in the recovery trial, and low-dose anticoagulation. That is the backbone of therapy for severe Omicron or patients who require hospitalization. Thank you.
Thank you very much, Dr. Graham. And now that we've heard from our panelists, dear journalists, it's your turn to ask questions. And again, as a reminder to do this, use the question function on the Zoom application and not the chat option. Please remember, you will need to provide your name and the news agency that you represent for us to have your question asked. And if would like to go live with your question, we shall also give you an opportunity. Feel free to let us know. We also have on hand Mr. Alan Poi, the Regional Immunization Monitoring and Evaluation Officer. And also we have Dr. Nixie Gumede, who is our Regional Virologist. And they're also on hand to answer your questions. Our first question comes from Emery Makunmeno from BBC and goes to you, Dr. Gay. And then I'll also ask Dr. Graham to weigh in. And the question is, can COVID-19 end in 2022? Over to you, Dr. Gay.
We would like to see COVID-19 ending on 2022, but it will need a lot of work in terms of vaccination, in terms of detecting the cases and treating them, isolate them from the population, and in terms also for the community to respect the social distancing. Whatever is the case, even if COVID-19 is not ending on 2022, we will be working with the population and with government to make sure that COVID-19 will have less impact in the economy and in the day-to-day life. The response that is short is we don't know, but we are working hard to get COVID-19 ended on 2022.
Thank you, Dr. Gay. Over to you, Dr. Graham, to hear your opinion on this.
So I believe that COVID-19 is never going to So I am of the belief that COVID-19 is going to be with us for our lifetimes, and we will be unable to provide global containment and eradication of this virus, and that we should push towards mitigation, and we will live with this disease instead of it being a pandemic, but it will become endemic globally. The only way we can, in fact, mitigate this disease is through widespread vaccination and the use of other mitigation strategies, including non-pharmaceutical interventions, mask wearing, hand washing, and social distancing.
Thank you. In short, we still have the virus with us, only that we need to be the ones in control. So our next question will come from Paul Adepo, and Paul Adepo, you have the opportunity to go live with your question.
Yeah, thank you very much. So I have, I will take the question from where Dr. Graham stopped, which is preparing for endemicity. We, as Africa struggles to quickly roll out vaccines, what are the WHO Africa region's longer-term plan towards ensuring sustainable and reliable availability of COVID-19 vaccines beyond just the surge that we are seeing presently? And for Dr. Graham, I also want to ask what difference do you think news about WHO's approval of new drugs, especially the one from Pfizer, could make in improving outcomes for patients with that needs hospitalization. And the US and the UK are also struggling to quickly have abundant testing kits. I want to know if WHO African region has any concerns about the continent running out of rapid antigen testing kits anytime soon. Thank you very much.
Over to you, Dr. Graham.
All right, I'll respond to my part of the question, which was, what do I think news about the approval of new drugs in the treatment of COVID will have on the impact of COVID? So I think there's two parts to this question. The first is that treatment assumes that we have failed and allowed our patients to acquire severe infection, and we have unvaccinated our population. So once we have failed and we are dealing with a population who has now severe disease, we need to think about pharmaceutical management. And there definitely are agents like the new Pfizer drug that has a therapeutic advantage, decreases the chances of death or ICU admissions. And these drugs have been shown with early evidence to work. However, they come with contingencies, and this is mostly cost and availability. And we're dealing with a continent that doesn't necessarily have the ability to afford rollout of large numbers of these sort of drugs to populations who would require them. So I don't think that is an isolated solution, although I do think it is part of the plan and part of the way forward in treating severe COVID.
Thank you very much. Dr. Gay, would you like to weigh in into this question?
Thank you very much. I will start with the first question and let Alan complement, and also some idea related to the test, care, and treat about COVID-19 in Africa. The first, sustainability of reliable vaccine beyond in 2022. We can tell you that in 2022 in Africa, the countries that express the need to receive vaccine will receive it, and they will receive enough vaccine. The pipeline has many vaccine, and at all days we are offering to countries vaccine. The problem will be though, what we are doing in terms of operationalizing those vaccination in the country, for taking them from the capital to where they are needed, including at the sub-regional level. It is also about finding the right strategy in order to provide vaccine to all the people who are demanding for vaccine. We may believe that the African do not want to be vaccinated. Some study have been done. The recent one was sponsored by the World Bank, where African for over 80% are demanding vaccine and accept vaccine when they are offered that vaccination. So there is a positive side if the government are working toward a good operationalization of that vaccination. Now, in terms of the new drug and testing, COVID-19 is the first pandemic of this on our lifetime and of this level, and it has so much impact, but it is not the only pandemic that existed. There is others that happened that was also very deadly, like the HIV, and testing, treating was a pivotal resources that were used to fight those diseases. And I do believe also in the third years of COVID-19, testing, caring for patients and treating them will be an important pillar to develop at all countries. And it will not be about only for the cases that are severe or critical. It will be for almost all the cases where something may be done. Because if the treatment is done appropriately and on time, it might limit the infection of other patients. So testing and caring and treating is a priority for WHO, and we are working with countries already in order to do the best to scale it up. Thank you.
Thank you very much. So now we go to questions that are coming in from Abigail Tembo from Zimbabwe Broadcasting Corporation, I want to believe. Yes, from Zimbabwe Broadcasting Corporation, and Abigail has 3 questions. The first two questions will go to you, Alan Poi, and then the last one will be to you, Dr. Gay. So the first question is, how is the vaccination progress in Africa? And the second question to you, Alan Poi, is which 7 countries have met the vaccination deadlines? Then to you, Dr. Gay, how many COVID-19 variants are in circulation world over? Mr. Poi.
Thank you very much, Fiona. Good morning, colleague. To start by the first question, how is vaccination progressing in Africa? As already mentioned by Dr. Gay, we are actually at only 10% of the African population that are fully vaccinated, which stand at 136 million people that are fully vaccinated out of over 1 billion as target. We also need to know that we have 26 countries that already reached the first target that we had for September 2021, which was to reach at least 10% of the population fully vaccinated. We now have 7 countries that have reached the December target, which was to vaccinate at least 40% of the population with complete series of doses. Those 7 countries are actually Seychelles, Mauritius, Morocco, Tunisia, Cabo Verde, Botswana, and Rwanda. So those are the 7 countries that have reached the December target. But we already have 2 countries that have already reached the mid-2022 target, which is 70% of the population fully vaccinated. And those 2 countries are Seychelles and Mauritius. So in summary, we vaccinate around 6 million every week, fully vaccinated in Africa. But for us to reach the end target, which is the June 2020 target, 2022 target of 70%, we need to vaccinate close to 34 million weekly. So Africa has to go from 6 million to 34 million every week of number of people fully vaccinated. You can see how the work is still to be done. As Dr. Gay said, countries have to put in place mechanisms to accelerate the process of reaching people, including by making sure that infodemics are tackled, but also the service delivery component need to be very, very well organized and started. Thank you very much.
Thank you very much, Alan. Over to you, Dr. Gay.
The variant in viruses is something that exists, and every time that a virus changes from an individual to another, or a variant multiply, there is the chances that happen. So far in COVID-19, we are talking about hundreds of variants that have been identified overall in the world. But it's not all those variants that have impact on the epidemiology and on the clinics. Actually, in Africa, we have identified 7 variants that are variant of concern, and there is 3 variants that are variant of interest, and there is other variant also that exist. What is important is that so far, the variant may have some impact on the epidemiology and may have impact also on the clinic, but related to vaccination, the vaccination is still capable of protecting people against death and the critical cases. And we are still monitoring the variant, and WHO has a program that is expanded on the 3 sub-regions of Africa. One is on the west, and another is on the east and central, and another program in the southern part of Africa. And those are supporting all our 47 member states to develop their capacity for genomic sequencing and pathogen surveillance in order to detect the variant as early as possible, being able to describe their behavior in terms of epidemiology and clinic, and be able to advise the decision maker for responses. Thank you.
Thank you again, Dr. Gay. And in your expertise as a clinician, Dr. Graham, the next question from Janice Q from Bloomberg is for you. Is Omicron having less effect on people's lungs?
So I don't want to be too reductive in my answer because Omicron is a severe variant in people who are at risk, which means if they are unvaccinated or they have comorbidities and they are elderly, yes, it's going to have a severe impact potentially on their lungs, just as the other variants would. There may be some inherent or intrinsic, less, maybe inherently a little bit less virulent, but at the moment we still see some very severe lung disease in patients infected with Omicron who are elderly, unvaccinated, and with comorbidities.
Thank you, Dr. Graham. Our next question goes to you, Dr. Gay, and it's from Lindsay Chattel with New York Times. And she says, much of the data we have on Omicron comes from South Africa, where vaccination rates are higher than elsewhere on the continent. Do we have any data yet on how widespread Omicron is in other parts of Africa? And how is it presenting in unvaccinated populations? Is it in fact less severe as we have seen in South Africa?
Thank you very much. Just to note that in general, the data we are having in Africa mostly are coming from South Africa. If you see the cumulative data reported for COVID-19 in general, 35 of them came from South Africa. So it is expected that in Omicron, that first was reported in South Africa, we have more data from South Africa. We are continuing to monitor and getting results from other African countries. So far, 30 African countries have reported the case of Omicron into the general global database. We should admit that it is more than that, because some countries may not detect it or may have detected and are in the process of reporting those cases of Omicron. What was the next part of the question? You are muted, I believe.
So the next part of the question is has it presented as less severe in, how is the Omicron presenting in other populations in other countries with less vaccinated people?
Okay. In general, the data we have from other countries, we have less proportion of severe and critical cases of COVID-19 from the Omicron infection. However, as Dr. Graham said, it is a severe disease. It's when it is a population that are at risk, population that are immunodeprived, or population that are older. So it is actually behaving like the other variant that was already reported. But in general, the number of cases does not translate in a huge increase on the number of deaths.
Thank you very much, Dr. Salam. And while you're still at it, the next question again from Lindsay is the WHO strategy to combat COVID-19 in Africa going to expand beyond vaccines and non-pharmaceutical measures, include lobbying to acquire new treatments like COVID-19 pills from Merck and Pfizer?
That's what I was saying on my introductory remark. The COVID-19 response strategy is based first on vaccination. It is a product that exists, work, and Africa has a lot of experience delivering vaccination. And I believe that we have a comparative advantage and we have to find our way to vaccinate our population. The public health and social measures exist. They are effective at the individual level. There is some that have huge impact on the economy that understandably many governments are reluctant to take. And many communities also, even if the government decided, they are not accepting it. We are working in trying to find the fine balance in advising those governments to apply the public health measure. The third strategy that I was talking about is to test, care, and treat. to test as much as we can. Ideally, it would be to have a self-test that people would be using and to be making the rapid antigen diagnostic testing, which is something that is feasible in most African part where the PCR is not possible. The RDT are very effective now. Their sensitivity, their specificity are very good. And even compared to PCR, taking into account the other environmental factor and the other capacity and possibility of the health workers, RDT is a good option. And we will work to increase the availability and the use of RDT with our member state. And finally, for the care and treat, it's not about only treating those who are at who have severe cases or who have critical cases. We do believe that with the discovery and the coming of new drugs, it will be the pills, it will be possible and recommended to treat even the mild cases. Because once they are treated, not only it is an improvement on the general situation of the patients, but also it may help on the epidemiologic side, because those patients will not be transmitting the disease to many people because they have not had the disease for a long time. And maybe also the viral load will be reduced very quickly when we start those treatments. Thank you.
Thank you for that detailed explanation, Dr. Gay. So our next question is to you, Alan Poy, and it's coming from Christina Okello, who is a journalist at Radio France International. So the question is, what is the World Health Organization's position on booster jabs? In Ghana, for instance, a group of concerned doctors have issued a petition against mandatory COVID-19 vaccination, saying perpetual boosters are costly and ineffective. So what is your view? And Dr. Gay, I'll also request you to say something about this.
Merci
just
beaucoup.
very quickly, yeah, in French, thanks.
Merci beaucoup. Comme la question vient de Radio France Internationale, nous allons y répondre en français. Alors, c'est une question intéressante. Il est vrai que la position de l'OMS est toujours contre la vaccination obligatoire. Ça, c'est un fait. Mais les pays sont libres de prendre des décisions qu'il faut pour protéger leur population. Mais pour l'OMS, il n'est pas question d'imposer la vaccination. Alors, le booster dose, il est important pour justement compléter l'immunité pour les personnes qui ont des problèmes de santé. Mais il convient de signaler que le booster pour la troisième dose ne doit pas se faire au détriment des personnes qui n'ont même pas encore reçu une seule dose. Cela veut dire, si on a des personnes qui n'ont aucune dose de vaccin et qui ont besoin de le recevoir, et à côté, on a des personnes qui en ont déjà le 2 et qui ont besoin de booster dose, le choix, forcément, c'est de commencer par ceux qui n'ont rien. Mais quand on est dans la situation où la majorité a été vaccinée et qu'il y a les moyens, les pays disposent de vaccins suffisants pour donner les booster doses, justement, le pays est libre de les faire. Merci beaucoup.
Thank you, Alan. Dr. Gay, anything to add on that?
OK, merci beaucoup. La première chose est que le booster dose, qui peut être la deuxième dose ou bien la troisième dose, selon le vaccin que vous avez utilisé, est efficace au niveau individuel. Ça diminue le risque d'attraper la maladie. Et aussi, quand vous attrapez la maladie, ça diminue le risque de mourir de cette maladie. Maintenant, au niveau communautaire, est-ce qu'il est mieux de donner une troisième, voire même une quatrième dose à un enfant au moment où des personnes à risque dans des pays limitrophes ou pas loin, parce que maintenant, avec le développement de la communication et du transport, aucun pays n'est loin de l'autre. Est-ce qu'il est beaucoup plus intelligent de donner ces vaccins à ces pays-là qui n'ont pas la première dose, particulièrement c'est les personnes vulnérables, que de le donner à des enfants? Je crois que la réponse est automatique. Il est mieux pour la communauté que les doses disponibles soient distribuées à là où on en a besoin et qu'on les supporte sur le plan ressources à mettre en place des stratégies de vaccination qui permettent que les vaccins arrivent à la peau de la personne qui en a besoin. Maintenant, il y a un autre effet qu'on est en train de discuter qui a été soulevé par certains de nos collègues au Ghana, comme vous l'avez dit. Est-ce qu'on peut continuer tous les 6 mois à vacciner 7 milliards d'individus? Je sais que ça va poser un problème et il est bien que la communauté, l'OMS, y compris les autres scientifiques africains qui ont beaucoup d'expérience, se penchent sur la question et voient quelle est la meilleure façon d'être efficient, c'est-à-dire dans notre utilisation de notre ressource, comment on peut sauver le maximum de vies et comment on peut faire pour faire réduire la souffrance, c'est les Africains. C'est une question ouverte. Je ne dirais pas qu'ils ont raison ou bien qu'ils ont tort, mais c'est une question qu'ils ont le droit de mettre sur la table et qu'ils ont même le mérite d'avoir mis sur la table et on en discute et l'OMS aussi va donner des recommandations dans ce sens.
All right, thank you very much. Indeed, very many questions that are coming in. Our next question is for you, Dr. Graham from Sarah Jevin with DEVEX, and says, you spoke about, Dr. Anita Graham spoke about seroprevalence in the population. Is that 70% from South Africa or Johannesburg? And I've had speculation that previous natural infection from other variants offers limited protection against Omicron. Can you talk about the current research around protection that previous infection provides against Omicron? Over to you, Dr. Graham.
Thanks for the question. I think this is a very complex question and we don't have all the answers as of yet, since Omicron is quite new. It's quite a new variant. And I believe we also need to look at the timing of previous infection. For example, if previous infection happened during the first wave, what is likely to have occurred is that with time, there's natural waning of immunity, and therefore there will be no leftover residual antibodies to fight a new variant because there's no leftover residual response. However, we have seen that we've got a seroprevalence of around 70%. That's in some of the data that's come out of the Western Cape from the second and the third wave. And that may be why we are partially seeing a less severe fourth wave, although my belief system is that it's multifactorial why we're seeing less severity. Natural seroprevalence together with vaccination and together with a variant that may be in fact less virulent, but that data is still emerging. So it's not, I can't give a complete straight answer in saying that yes, having a previous infection gives you less protection against Omicron. We can't definitively say that. It's depending on the severity of your infection, your antibody response, your immune response. You may get an attenuated infection with Omicron, but it may not be as severe. It may keep you out of hospital if you've previously had an infection because you still have a T cell sort of antibody immune response, even though you have a poor antibody response. So there's lots of parts of that question that still need to be answered.
Thank you very much. And while it's still at it, Dr. Graham, we have a question from James Macharia Chege at Reuters, who has 2 questions, and I'll give the first one to you, and then I'll ask Dr. Gay to also make a statement on that. Who is being hospitalized in Africa at the moment? Is it the vaccinated or unvaccinated? Or is it the elderly?
So it is a broad spectrum of patients that are being hospitalized. I work in an adult hospital, so I can only really speak towards the adult population that I see that's hospitalized. And anecdotally, I can say that I have not had a single patient hospitalized that is fully vaccinated. The patients that we have hospitalized are patients who are unvaccinated, patients who are partially vaccinated, patients who have been vaccinated more than a year ago, so it's likely their immunity has waned, and patients who have severe comorbidities. Having said that, patients who have severe comorbidities who have been vaccinated and are found to be COVID positive and admitted are often being admitted for non-COVID related disease. For example, they're being admitted actually for cancer, a cancer issue, and they coincidentally swab positive for Omicron.
Wow, what a rude awakening. So Dr. Gay, I will ask you to also say something about that, but while also answering that, there was a question on have Omicron infections reached a peak in Africa or not?
Thank you very much. The first, for the hospitalization, we have received some data that are not completely scientific because it may have some bias due to where they are reporting and where the data was selected. It kind of confirms what Dr. Graham has already said. So far, there is very limited cases where we have severe or death when it is a person who was fully vaccinated in the last year. And the previous infection also has been very correlated with having a mild diseases. So the immunocompetent who are vaccinated or who may have had an previous infection, whether it is Omicron, Delta, or other previous variant, are unlikely to have a severe disease or to die with it. The other question is about if there is a plateau for this fourth wave, yes or no. During the last 2 weeks, there is a plateau. It is a fact, dependent on the report we are receiving from our member state. As epidemiologists working in several other cases, and even in COVID-19, we have noticed that, for example, the weekends, it is always low compared to the rest of the week because the surveillance system is not working properly in some countries during the weekend. During the holiday also, it is something that happened, whether it is between December 24 to December 31st or the first week of the year. Usually the number of cases that are reported are below what we used to receive. So being very cautious, we're gonna say that it is plateaued, that's what we receive, but we are careful and we are observing for the upcoming couple of weeks to make sure that this wave is going on. And particularly that this plateau happened earlier than in the other waves. So if this plateau is confirmed, it means that the fourth wave that is determined by Omicron has less time than the other wave, but it needs to be confirmed first.
Okay, so means that we are on a watchful waiting for the data to accumulate out of the holiday season. Our next question is to you, Alan Poi. What can be done to curb vaccination reluctancy? And Dr. Gay, I know that you also have, with your vast experience in emergencies involving vaccination, you can also tell us what can be done to curb vaccination hesitancy.
Thank you very much. That's a very interesting question. To be able to sort this issue of vaccination hesitancy out, we have different ways of doing it. One of them is to avoid taking all countries as one. Even in countries, avoid going the same solution everywhere. The starting point is to understand why a given community is reluctant to vaccination. And once we understand this reason, we should be able now to implement corrective actions, discuss with those communities, try to convince them, and then to, if possible, transform them to champions. So just one example, we have seen that the healthcare worker community is one of very reluctant body in COVID vaccination. So starting by convincing them and turn them into vaccination champions can have very good results. We got a number report that came from Nigeria about a survey that was conducted about COVID acceptance in the community. We have seen that all type of communities have some kind of number of people that are reluctant to vaccination. So it's not only for one category, it is across the board. And in summary, The key point is to understand the real reasons why people are not accepting or are reluctant to vaccination, and then to implement activities that will sort it out. And micro plans that have started being implemented in countries is one of them, where countries are being able to identify which communities are latent and how to implement activities to reach them and turn them to vaccination champions. Thank you very much.
Thank you, Alan. And as you come on board to say more about this, Dr. Gay, I would like you to take that question with another question from Laura Lopez Gonzalez from the continent. And she says, last year, your office conducted a survey of African countries that had access to basic COVID-19 treatment drugs. How many countries are able to access any treatment medication?
Yeah, let's start for the vaccine hesitancy. It is an important issue in the world and also in Africa. But let's not give too much consideration to what we are talking about, the vaccine hesitation. Some people may just believe that the Africans are not vaccinated because of they are hesitant to vaccine. The Africans are not vaccinated because they don't have vaccine. The Africans are not vaccinated because there is not enough resources to operationalize those vaccinations and bring them to where they are needed and when they are needed. There is a survey that was done, sponsored by World Bank in 6 African countries, where the vaccine acceptance was found to be one of the highest in the world. In a country like Ethiopia, over 100 million inhabitants, over 97 of the people that were questioned say they would take a vaccine if they were offered that vaccine. All the other countries that was surveyed had a rate of acceptance over 80%, except Mali, that were at over 65% that acceptance rate, which means that the vaccine hesitancy exists, but it do not have such a big impact on why the Africans are not vaccinated. So why there is that vaccine hesitancy also? That same study have done it, and there is a lot of reason. The most one is don't think it will be safe, worried about side effects, don't think it will work against vaccine in general. And why those people are having such a wrong perception of the vaccine. It depends often to those offering them that vaccine and what are the medium and how they did it. Our expert in risk communication and community engagement try to understand first the population, what are their preoccupations, what are their relationship with government, what are the level of trust they have had with those government. When you go to countries in crisis, when you go to countries that are corrupt, and when you go to countries sometimes where the government had not been very reliable and helpful to their population, it makes sense that they resist to vaccine. They would have resisted to everything because they do not have reason to trust those who brought the vaccine. And it is the general work we should be doing on that. The other question was,
the other question was on the survey that was done by Afro, and how many countries do indeed have access to any treatment medication?
COVID-19 treatment.
True.
Yeah, unfortunately, I don't recall all those numbers. We would be happy to provide it after this conference, but I don't have the number of countries that have the treatment. I know that 4 countries only went ahead and bought some treatments, even though over 10 countries expresses the need to have it. But when they know the cost of the treatment, they found that buying those treatments with the budget was not cost efficient, and they choose to not buy. It's only 4 countries that finally decided to buy it. But it should be noted that it is not only the government that can buy treatment. Some organizations from the United Nations, NGOs, and other entities may buy it. So that's what make it, for me, I don't have the data that could tell you how many countries have treatment available today, but we have those data and we should be able to provide it to you after this conference if you wish.
Thank you. Again, yes, indeed, we can provide information to the journalists after this. Our next question comes to you, Dr. Gumede, our regional virologist, and it's from Renee Bonoshis from Bloomberg News. Do you have any information about the variant dubbed Delta Cron in Cyprus? Is there a reason suggesting, is there research suggesting that it could be a variant of concern?
Thank you so much, Fiona. As we know that while we are still facing population that are really under-immunized, so the co-infection is quite very possible. So as you know that when you're talking about Delta Cron, is when a person is infected by both Delta variant as well as Omicron variant, which is quite possible. But focusing on the Cyprus variant itself, that variant or that findings is still under investigation, because there might be a possibility of some laboratory issues concerning the results that were reported related to Delta Cron. But co-infection at this point in time is quite very, very possible. As you know that recently we just also heard about the Florona, where people were having both influenza infection as well as the Omicron infection. So the bottom line and the take-home message for this, we are still really pleading to the population that the best weapon to fight all of these variants that are really emerging in the world is to make sure that we get some vaccination as soon as possible. Over.
Thank you, Dr. Gumede. Sounds like from all speakers, vaccination is our way to get out of this pandemic. The next question again comes to you, Dr. Gay. Should countries continue to lock down to break the chains of transmission, or should they loosen up a little? This is from Kayelile Kumalo from SABC News in Johannesburg.
In general, countries should not lock down, but in particular cases, it may be necessary to do a lockdown when it is cost efficient, when there is a variant that is very dangerous and transmissible. A lockdown may be a measure only to buy time in order to put in place some responses capacity, to put in place some treatment capacity, and open up and loosen a little bit. A lockdown, by experience, have a huge impact on livelihood, have an impact on the economy, and also the population do not like it, and you may not receive their full collaboration on this fight. As long as you don't have the full collaboration of the population in a fight against an outbreak, a pandemic, epidemic, it will not work. So lockdown should be reserved to exceptional cases.
Thank you. I think that's excellent news to the ears of the population. So James Macharia Chege from Reuters once again is back with two more questions. And one goes to you, Alan Poi. Do you have details on whether Eritrea has begun vaccinations? And then the second one is, are there any details on whether African countries are getting treatments from Pfizer and Merck pills on the continent? This goes to you, Dr. Graham.
Thank you very much. For the case of Eritrea, as far as we know, the country has not started vaccination. We have seen countries where even officially the country has not started, but some special organizations like embassies or UN could get vaccinated. It may be the case in Eritrea, but officially, we know that the country has not yet started vaccination, and that's the only country in our continent in that status. Thank you very much.
Hi, thanks. Can you please repeat the question? I was unable to hear the end of it.
So the question is, are there any details on whether African countries are getting treatments from Pfizer and Merck on the Pfizer and Merck pills?
So I'm unable to truly comment on this because some of these pills have only been recently authorized by the FDA for use in North America. And from what I understand, in South Africa, they're not officially available yet. I think it's a matter of time until the South African Medical and Research Council gets an application for it and they process the safety and then decide whether or not they will be rolled out in South Africa and available. But it's also likely that this will be something that patients will have to purchase themselves, at least in the beginning, until the governments can consider whether or not it's cost effective to purchase these agents.
Very helpful. And as we come towards the end of this press conference, the last question comes to you, Alan Hoy, and it's from Janice Q from Bloomberg again. The question is, can you comment further on the plan to deploy experts to help ensure countries that are struggling to get shots in arms are better able to do that?
Thank you very much. In fact, for us to be able to first identify which countries to prioritize, we conducted a risk assessment of countries not being able to achieve the set target. So this risk came up with 4 categories. We had 7 countries, 13 countries that are at very high risk. These 13 countries are countries that are in our top priority list, but we also got 23 countries which are at high risk. So we took the 13 countries of very high risk and 7 countries of high risk with the high population or these countries were prioritized. So just next week, we'll organize a briefing of consultant that will be sent to these 20 countries, which is composed of epidemiologists, data experts, logisticians, and experts on immunization to go and work with country teams, both from WHO, partners, and MOH to tackle issues that are hampering vaccine uptake. And this may end up by having a need to send more experts in order to have a revised plans for each country to get the 70% target by mid-June 2022. Over.
All right, thank you, Alan Hoy. And we see we are all trending towards the vision, 70% population fully vaccinated by June 2022. So we've come to the end of our virtual press conference, but before we close out, let's turn to our panelists to hear any final messages. You have a minute each, and I'll start with you, Dr. Graham.
Thank you again for this opportunity. My final message I'd love to give to the general public is that regardless of the current variant we live with at the moment, whether it's Omicron, Delta, or Beta, or one of the ancestral COVID variants, is that the backbone against protection from severe illness and protecting our vulnerable populations, the elderly, the immunosuppressed, will remain vaccination. And it is the best thing that we can promote. And prevention, I strongly believe, is always better than cure. And secondly is non-pharmaceutical interventions. But I think the emphasis for our population should be communication and enhancement of uptake of vaccinations. Thanks.
Thank you, and thanks again for joining us today. So to you, Dr. Gay, to close us off with your last words.
Yeah, start with thanking our members of the panel, Dr. Graham, Dr. Poi, for really participating on this. And we are really looking forward continuing the work together for giving the right information to the population. The priority for 2022 are first for the vaccination to make sure that shots are arriving at the arm of the African. Actually, we will have the doses that are necessary. The rest of the mile is very difficult, but we have a way to do it. We have done it in the past, and we will do it now. The second is about the social measure. For the social measure, I think there is also some measure that was done. We will continue to work with the community to make sure that they are vaccinated, they have masks, take their distance, and wash their hands regularly. That may protect them to get the COVID-19, or when they get the COVID-19, will not have the severe disease or they're going to end up with death. There is a new way, that is the testing, caring, and treatment of patients. Because of new development, we're going to have new pills that are going to help the clinician. And we do believe that on the 2022, all those will be increased in Africa, and particularly with the initiative of ACT, where a lot of work are being done in negotiation with the pharmaceutical companies in order to make sure that Africa will have access to the treatment that are necessary for the caring and of patients. And finally, the fourth wave has plateaued for the last couple of weeks. We hope that it may continue, but also in case it's not continuing, the fight will continue, and we will do it together with the community. Again, I do believe that the community is the first fighter. That's the community that's going to succeed on this with our support, but not the opposite. And so we're just going to ask to all Africans to consider this as their own fight, even if they may not be at the population at risk. Thank you very much, everybody.
Thank you. Thank you very much to our panelists. Thank you to the journalists for joining us, and wish you all a good day.